you could be brought to that sort of position, that would be 90 degrees. We then test leg lengths using a tape measure, and there are two types of leg length to be considered. There is the so-called true leg length, which we measure from the anterior superior iliac spine, which is usually easily palpable in thin people, to the tip of the medial or the lateral malleolus. And we measure this and record it in centimeters, comparing the right side with the left side. Any discrepancy in the true lengths of the legs must be occurring somewhere between the medial malleolus and the hip joint itself. We then test for apparent leg length, which is traditionally carried out by placing one end of the tape measure on the umbilicus, but because this frequently moves around, particularly in fat patients, it is more appropriate to put the tip of the tape measure on the xiphisternum, and again measure the length down to either the tip of the medial malleolus, as I'm doing in this case, or the tip of the lateral malleolus, whichever you prefer. And again recording this apparent length in centimeters. The thing about the apparent length is that if the patient has a fixed adduction contracture of the hip joint, in other words, this patient's hip is unable to move to the neutral position of abduction and adduction, in order to bring the leg out of the way of the other leg, the patient has to rotate the pelvis upwards, and in so doing, obviously, takes the leg with it and produces apparent shortening. The leg is short, but not because there's anything wrong with the leg between the hip and the malleolus, but because the pelvis itself has moved and taken the leg with it. And then finally we do turn the patient onto the face. If there hasn't been a flexion contracture demonstrated previously, and test out what the actual range of extension is by, again, the palm of the hand flat on the buttock to stabilize the pelvis and lifting the leg backwards off the bed. And this young man has about 15 to 20 degrees of true extension, which is the normal range. That concludes the examination of the hip joint. I'm now going to demonstrate the examination of this young man's right knee. First, we ask the patient to walk in order to detect whether or not he has a limp. You will see that this young man has a completely normal gait. We then examine the patient standing to see whether there is or isn't a deformity of the knee joint. With the medial aspects of both feet pressed firmly together, the medial aspects of both knees should be lightly touching each other. You will see in this man's case that this is not so, and he has therefore a slight bow leg or genu varum deformity. The opposite of this deformity is a knock-knee deformity or genu valgum, when, with both knees lightly pressed together, there is a gap between the medial malleoli of both ankles. We should then turn the patient around and observe the back of the knee joint to see whether or not there are any visible swellings in the popliteal fossa. The next part of the examination takes place on the examination couch in the supine position. During this part of the examination, we need first of all to look at the knee, and then feel the knee, and then finally move the knee. Beginning with inspection of the knee, we need to see whether or not there are any scars present, whether there is any redness around the knee, whether there are any swellings around the knee, and whether or not there is any evidence of quadriceps muscle wasting. You will see in this man's case that he has a very well developed quadriceps muscle, particularly the vastus medialis part of it. We then come to feel the knee. The first thing to do on feeling the knee is to actually measure the diameter of the quadriceps. This is done by marking a fixed point, usually about 10 centimeters above the upper border of the patella, with a pencil, and the same on the opposite knee, and then measuring the girth of the quadriceps with the tape measure at this point and comparing it with the opposite side. If we have observed any swelling in the suprapatellar pouch, we need to test for whether this is fluid or not. The way in which we do this is to milk this fluid down with the left hand so that it comes to lie, most of it, behind the kneecap, and then we tap the kneecap with the index and middle fingers of our right hand. In the normal situation, one does not get the feeling of the kneecap hitting the femoral condyles. If, however, there is fluid between the patella and the femoral condyles, when one taps on the kneecap, one will feel the kneecap move and then hit the femoral condyles. If this is the situation, we call it a positive patellar tap. We then need to feel the knee for localized tenderness and localized swellings. And in order to make any sense of this, we need to refresh our memories about certain aspects of the surface anatomy of the knee. None of you should have any difficulty in remembering that this is the kneecap, and that about a hand's breadth above the kneecap, in a sort of horseshoe shaped situation, is the suprapatellar pouch, which you remember communicates with the knee joint. Just below the kneecap there is the infrapatellar tendon, and this is attached to the tibial tuberosity. If we then bend the knee to approximately 90 degrees and run our index finger along the medial aspect of the proximal tibia, you will find that it falls into a slight depression. This point indicates the presence of the proximal end of the tibia and therefore the joint line on both sides. The joint line runs backwards, perpendicular to the tibia on the medial side and on the lateral side. Tenderness, therefore, along this line would indicate a problem with the meniscus. The articular surface of the femoral condyles is situated in this position, both medially and laterally. And tenderness in this situation would indicate problems with the articular cartilage of the femoral condyles and therefore osteoarthritis. Now the medial collateral ligament is attached to the medial femoral condyle at the medial epicondyle, and from there spreads out in triangular fashion down the medial surface of the proximal tibia. Tenderness, therefore, along this line would indicate problems with the ligament. The lateral collateral ligament arises from the lateral epicondyle of the femur and is a cord-like structure inserted into the fibular head. Tenderness along this line would indicate problems with the lateral collateral ligament. We need then to test for the integrity of these ligaments. First of all, I will demonstrate testing of the medial and lateral collateral ligaments. In order to do this, we have the knee fully extended, and to test the medial collateral ligament, we apply a valgus or outward strain to the tibia and observe whether or not the medial joint line opens up abnormally. If it does, it indicates not only a tear of the medial collateral ligament, but also, with the knee fully extended, a tear of the posterior capsule, because the posterior capsule is also a very strong structure and is tight in the fully extended position. We repeat the same test by applying a varus or inward movement of the tibia to test the integrity of the lateral collateral ligament. In order to overcome the posterior capsule masking any damage to the collateral ligaments alone, we flex the knee to about 30 degrees. This then relaxes the posterior capsule, and apply the same test, bringing the tibia first of all into valgus or outwards and seeing whether the knee joint opens up abnormally, and then secondly bringing the tibia into varus or inwards and seeing whether the lateral side opens up abnormally. Both these tests should be carried out and then compared with the opposite knee. We then test the integrity of the cruciate ligaments by flexing the knee to 90 degrees, sitting on the patient's foot to stabilize the leg in that position, placing one's hands behind the posterior aspect of the proximal tibia, and then seeing if we can draw the tibia abnormally forwards, and if we can, that is called a positive anterior draw test and indicates damage to the anterior cruciate ligament, or whether we can push the tibia abnormally backwards, and if we can, this indicates a positive posterior draw test indicating problems with the posterior cruciate ligament. We should then test movements of the knee. When the knee is fully extended, it should be possible to bring the femur and the tibia almost into a straight line. This we call full extension. If when we examine the patient we are not able to bring these two bones into a straight line, in other words there is loss of full extension, we refer to this as a flexion contracture, and we measure it from the number of degrees from the straight line position. It is also important to test that the patient can actively extend the knee by asking him to lift the leg off the bed, and this indicates that the quadriceps mechanism, the patella and the infrapatellar tendon are intact. We then examine flexion of the knee by bending it and measuring the angle between the femur and the tibia obtained. It is usually possible to bring at least half of the calf muscle to touch the back of the thigh. Again, this should be compared with the opposite side. And then it's important to remember that the knee also rotates, and we test this by flexing the knee to 90 degrees, holding the ankle and foot and rotating first of all inwards and then outwards. And I think you can see that the tibia rotates at the knee joint. We then ask the patient to turn onto his face in order that we may feel in the popliteal fossa, in this case in the left popliteal fossa, to see whether there are any swellings present or not, and if so, in which part of the popliteal fossa they lie. The final and very important part of the examination of the knee joint is carried out with the patient in the supine position again. This is in order for us to examine the range of movement in the hip joint. The reason for this is that in children particularly, serious conditions of the hip joint often present simply as pain in the knee. It is therefore very important in these patients to rule out the possibility of serious pathology in the hip. This concludes the examination. I'm now going to demonstrate examination of the lumbar spine in a patient presenting with backache. First, as was the case with examination of the hip and the knee, we ask the patient to walk. The reason for this is that many patients presenting with backache also have significant leg pain, which produces a limp. You will see again that this young man has a completely normal gait. We then examine the lumbar spine with the patient standing and look to see whether there is any deformity. Normally, the spinous processes all lie in a nice straight line. If there were a lateral deviation or curvature of the spine either to the left or to the right, we refer to this as a scoliosis. Also, when we run our finger down the spinous processes, we see whether or not there is a step present into which one's finger falls, as this would indicate that one vertebra had slipped abnormally forwards on the vertebra below, and this we call a spondylolisthesis. We then test the range of movement of the lumbar spine. First of all, we ask the patient to bend forwards, and this is flexion of the spine, and we record this as how near the floor he can put his fingertips. That's fine. Secondly, we test extension of the lumbar spine by asking him to lean backwards as far as he can. We then test lateral flexion of the lumbar spine to the left side and the right. In this case to the left side, and we see how far down the leg he can bring his fingertips to lie, normally to just below the knee joint level, and similarly on the right side. And then finally, we test rotation of the spine by stabilizing the pelvis and asking the patient to twist, first of all to the left and then to the right. The next part of the examination takes place on the examination couch with the patient in the supine position. We need to carry out an orthopedic type neurological examination of the lower limbs, as frequently painful conditions of the spine, for example prolapsed intervertebral discs, produce abnormal findings in the lower limbs. We carry out the straight leg raising test by asking the patient to fully relax, and taking hold of the foot, we see how far we can lift the leg, keeping the knee straight. Normally, it is possible to bring the leg to about 80 or 90 degrees without any problem. We do this first on the left side, and then we repeat it on the right side. In a patient with sciatica, that is pain radiating down the back of the leg, when we carry out the straight leg raising test, for example on the right side, the patient may begin to complain of pain at about 40 degrees of straight leg raising. If this is so, we place the foot on the examiner's shoulder, and if this pain is due to tension in the sciatic nerve, for example from a prolapsed disc, the pain should disappear when we gently flex the knee, as this obviously reduces the tension of the sciatic nerve. We then press on the hamstring tendons either side of the popliteal fossa, and they reproduce the pain. If we then press sharply on the has the effect of bowstringing the nerve and reproducing the pain in the patient's leg in the presence of a significant disc prolapse. All these maneuvers need to be carried out in order to establish with certainty whether or not the patient has a genuine positive straight leg raising test. We then test for evidence of nerve root pressure, for example from a prolapsed intervertebral disc, seeing whether there is any reflex change, sensory change or motor weakness. We'll start with testing the reflexes, getting the patient with his heels on the bed to bend his knees and tapping the infrapatellar tendon. These are normal. We then carry out the ankle jerk in this way and in the opposite leg, and again these are normal. And we then scratch the bottom of the feet to make sure that the plantar responses are downgoing. Absence of a knee jerk indicates a lesion of the L3-4 nerve roots. Absence of the ankle jerk, the S1 nerve root, and if the toes are upgoing, it indicates some upper motor neuron problem in the spine. We then very quickly test for sensation in the various dermatomes of the leg by lightly stroking the skin with our own fingers on the lateral border of the foot and asking the patient whether it feels the same both sides. Yeah. Any change in this would indicate problems in the S1 nerve root distribution. On the dorsal aspect of the foot, in line of the first web space, yeah. L5. Medial aspect of the tibia, L4. Yeah. And again, up the back of the calf and back of the thigh, S1. It may be necessary in cases of high backache to test sensation in the 3 front thighs. And very occasionally it is important to test for perineal sensation, which is S2 and 3. We then test motor power, first of all by testing the power of the extensor hallucis longus, asking the patient to dorsiflex both great toes and making sure that he has full power. EHL is innervated from the L5 nerve root. And if there is an abnormality here, we would then go on and test dorsiflexion of the ankle, asking the patient to dorsiflex the ankle, and again testing for power. Again, this is L5 nerve root. S1 nerve root is plantarflexion of the great toe and toes. We ask him to curl his toes up and see if he can maintain that plantarflex position. And similarly with plantarflexion of the foot, also innervated by S1, press the feet down as hard as you can and make sure that he has full power. It may then be necessary to go on and test for the power of knee extension, which is L2-3, by asking him to hold the knee straight, and the examiner tries and bends it. And similarly, power of knee flexion, holding the knee bent, and the examiner trying to straighten it. We then ask the patient to turn over into the prone position, and carry out the femoral nerve stretch test, which is the opposite to the sciatic nerve stretch test, by flexing the knee fully in this position. And if it is not possible to do this, it indicates increased tension along the line of the femoral nerve, for example from a high prolapsed lumbar disc. And then finally we examine the back by palpating the spinous processes in the lumbar region to see whether we can elicit any localized tenderness, and palpate the buttock and the back of the thigh to make sure there are no tumors present along the line of the sciatic nerve, which could simulate sciatica from a back problem. In certain circumstances, a rectal and/or vaginal examination may be required to rule out the possibility of intrapelvic disease presenting as low back pain and sciatica. This then concludes the examination of the lumbar spine in a patient presenting with backache.